So good afternoon, everyone, and welcome to another wonderful month of our school nurse program, our December edition. I'm lucky to be joined here by Dr. Feinelt and Sharon Goodman from Cohen Children's, who you'll meet in just one second. I'm sure I know many of you, but just in case I don't, Michelle Rader, I oversee our school-based programs over at Cohen Children's. Just a couple of housekeeping items for us tonight. Just a reminder to keep our mics muted and our cameras turned off. Today's session is being recorded. The recording will be available early next week for us to share, so you will receive that link. Everyone who attends our live session today will receive continuing education credits for your attendance here. That email will be automatically generated from the RedCap system to ask you to fill out the evaluation form. If you have been hanging out with us for a while, you know exactly what that looks like and what that process is. If you're new, I will share our email with you, and you can always follow up and ask for some clarification along the way. Without further ado, just to get us quickly started, I am happy to pass it over to Sharon Goodman, who's going to introduce our speaker for today.
Thank you so much, Michelle. So it is my pleasure to introduce our speaker today. Dr. Feinelt is an assistant professor and director of pediatric dermatology for the Department of Dermatology at the Donald and Barbara Zucker School of Medicine at Hofstra and Northwell. She is board certified in dermatology as well as pediatric dermatology by the American Board of Dermatology. Dr. Feinelt earned her medical degree from Stony Brook University, where she was elected to the Gold Humanism Honor Society. She completed her internship in pediatrics at Cohen Children's Medical Center and her residency in dermatology at Stony Brook University, where she served as chief resident. She completed her pediatric dermatology fellowship at Lurie Children's Hospital at Northwestern University. She is an active member of the Society for Pediatric Dermatology, where she serves on the Committee for International Outreach and Global Alliances. She is a member of the Pediatric Dermatology Research Alliance. Additionally, she is also the liaison of the Long Island Dermatology Society to the American Academy of Dermatology. Dr. Feinelt's specialties expertise is interdisciplinary based in care for patients with a broad spectrum of pediatric dermatology needs, including vascular growths, vascular malformations, eczema, nevi, and other birthmarks, acne, genetic skin diseases, psoriasis, alopecia, vitiligo, and other autoimmune and inflammatory conditions. It is my pleasure to introduce Dr. Feinelt for our speaking today on rashes in children of our school-age child.
Thank you so much for that introduction. If for any reason you can't hear me at any point, just let me know. I have no conflicts of interest. I have no kind of relevant disclosures, but you guys will note that I'm a bit biased. So today, it's not, hold on, there we go. My objectives today is that we're going to look at common skin rashes. We're going to discuss common things that you could see that could be caused by bacterial causes, viral causes, infestations, inflammatory lesions, as well as thinking about, what if these cutaneous lesions that I'm seeing, what if they're secondary to child abuse? And also kind of delving into a little bit of the social media craze and what the kids have been doing with the social media challenges. So when should our kiddos go home? When should they stay when they present with a potential rash to the nurse's office? So a quick rule of thumb, and this is a good reference point to use, is that if there's any areas that are like actively weeping that can't be covered, then, or if the kids are actively drooling, then they probably should not be there. But otherwise, this is kind of a good rule of thumb, and this is a good table from the American Academy of Pediatrics, looking at like when should the kids really not be there. And we have our guidance on COVID. I'm actually not going to be discussing much COVID because I think you guys are very well versed in regards to COVID related concerns, but this is really looking at the cutaneous concerns. So hold on, let me just make sure I could see this okay. So these are when the kids can stay. So if there's a rash without fever and no behavioral change, the kids don't need to go home. If there's lice or ringworm or scabies, then the kids should just be kind of referred to get it treated, but they don't have to be kept from school. They may need to be kept from sports activities, and we'll touch on specifically, you know, there's certain activities like wrestling where the kids will get everything from each other. Thrush, they don't need to be kept from. Fifth disease, by the time you see the rash in Fifth disease, the kid is no longer infectious, so that's not a reason to keep them from school. And a lot of kids can be colonized with bacteria that should not keep them from school, okay? So common things are common, like 1 in 5 kiddos will have some bit of eczema, and eczema tends to present as like weepy, sometimes rough, itchy skin. And we see this a lot. We see this on the hands, we see this on the extensors. Warts are common, molluscum are common, lice are common. So what does eczema look like? This is probably older than the patient that you see, but in short, there's these dry, rough patches. The kids can be scratching, they can get a little weepy. This is what eczema tends to look like. And in an older kiddo, it may just be limited to the creases of their arms, their legs, but these kids may be very uncomfortable. They may have trouble sleeping at night, so it may affect their concentration. They may be scratching in class. And this is a chronic condition. So this is not a condition that would necessitate somebody not being able to be in school, but it is something that will probably affect their performance in school. So this is something that we like to address. But again, it's a chronic condition, so we have to keep that in mind. And oftentimes, sorry, my light went off in my office. Oftentimes it can kind of flare and get better and flare and get better. And depending on the kiddo, depending on their like underlying genetic susceptibilities, this may be more challenging for certain kids to control than others. In different skin types, eczema can look a little bit different, but oftentimes if they've been scratching for a long time, the skin tends to get thicker and darker, and it can look this way. And these are the kiddos that, you know, sometimes the parents will bring in these sheets asking for you to apply certain medicines at school. I tend to tell them that my medicine should really go on twice a day. So they really shouldn't be asking you guys to apply any prescriptions to these areas, but they may ask you to apply like Vaseline or Aquaphor or things like that, which I think is reasonable. But really most of the medicine is applied twice a day. So that is not something that you would need to worry about. So what about other things that can cause a kiddo to get itchy? Some kids can develop allergic contact dermatitis. So that's actually an allergy to something that they're exposed to. And so commonly this could be something like poison ivy, where the kid get very, very itchy. They can have blistery types of rashes, and these can look pretty gnarly. They can be weepy, they can be uncomfortable, and it can be in a lot of different areas. Nickel's an interesting one because nickel is kind of in everything. And so even like with this kiddo in the picture, they had an allergy to their glasses. Nickel can sometimes be in their like remote controllers. Nickel could have also been in those little, the bolts that they used to have in my elementary school growing up. And so sometimes the seats have nickel too. So if the kids are wearing shorts, that could be a potential source of contact. Their belt loops, things like that. So there's a lot of different reasons for kids to be itchy. Sometimes even their personal care products can cause them to have allergic contact dermatitis. So this is another cause for them to be itchy, rashy, and this can be due to so many different things. This is what poison ivy can look like. And so typically a poison ivy rash will last for about 2 to 3 weeks, and it can be pretty miserable. But the thing that really tunes you to the fact that it's probably what we call an outside job, meaning something that they've been exposed to, is that it tends to have this kind of linear look to it. And the kid was probably fine preceding all of this, but they're kind of miserable. And whenever you have any sort of inflammation around the eye, it can really puff up. So that can happen with even aero allergens. So like, God forbid, somebody was like burning poison ivy, or their, you know, the landscapers were there and it was all getting aerosolized. It can really affect their face quite a bit, and they can puff up. Same thing if they got a really bad bug bite around their eye, it can really puff up their eye. But these tend to look weepy, crusty, and you can see how geographic these patterns are, you know, so if it's almost like they brushed up against it. And then you wonder like, well, how did it get in all these other places? Well, the kid probably touched it, and then it's an oil that's on the skin, and then it's spread around to other areas. But typically, you know, once they've showered, bathed, they're not potentially at risk for spreading this to somebody else. It's on them and they're having an allergic contact rash, okay? So they're not contagious to anybody else. My brother used to always joke, and I had poison ivy way too many times, that I was going to infect his friends with my poison ivy. That's not how it works, right? And on Long Island, we're pretty well versed with poison ivy, but this is how it can look. Irritant dermatitis. So kids oftentimes, and with the younger, like if you're in elementary school, you notice that the kids are sometimes like chewing on their mask. They're like nibbling on it, they're sucking on it. And so they may get a lot of irritation from their saliva. Okay, and we can see that around the mouth. Also, the hands are frequently affected. So like the slime craze did not do us well, being in a pandemic with all of the sanitizer use, with all the frequent hand washing, we can notice that the hands start getting really irritated. Also, unfortunately, a lot of people kind of were feeling like, oh, maybe essential oils will help, this will help. All of these things can be sources of irritation. And so we have to be aware of that. So appropriately moisturizing, appropriate barriers, like, switching out the mask if the kids are sucking on it and getting really irritated, those are things that can help. But it can be a little bit uncomfortable because if the kid starts eating like pizza or like pasta with spaghetti sauce, and they have these open raw areas that are so irritated, it may sting, it may burn, it may be pretty uncomfortable. But this is secondary to irritation. So meaning that it's not that they're allergic to it, but anybody, who would have experienced this amount of constant frequent irritation would get a rash from something like this. So that's what makes it different from an allergic contact dermatitis, where you have to have an underlying susceptibility to that allergy. So what about lice? Lice is super common. Actually, we surprisingly, I haven't been seeing too much of it, but sometimes we can get resistant lice. So that's tricky because this does have an over-the-counter treatment. This is what like an active lice looks like, but most often you don't actually see the actual lice crawling through the hair. If you do, you're kind of lucky because that's a big slam dunk. Typically you can see the knit, and this is so like a picture of what the knit looks like on the hair shaft, and it tends to kind of be confusing to tell it apart from like if a kid has like dried out gel in their hair, or if it's just kind of really prominent dandruff, which also is super, super common. But these tend to not move on the hair shaft. So this is actually like a little concretion. It's almost like a little glue that gets secreted, and so it sticks to the hair shaft. If you notice snits that are further away from the scalp, they're probably not viable. But lice, you can see it, but the other thing is that there's so many other things that look like lice. So the dandruff, the gel, and so psoriasis on the scalp, fungal infections on the scalp. But this is what those little knits look like. So you have to kind of look really closely. There are good treatments over the counter. If there is resistance, there are prescription treatments that we can do. Oftentimes when the kids like come home from sleepaway camp, there's the lice fairies that can actually manually remove the knits, but there really are simple treatments that we could do. It's just sometimes if the over-the-counter didn't do the job, it may have been a resistant strain, resistant lice, which is not fun, but it's okay. It's still manageable. So lice is common. We see it again. They could potentially spread other infections, but again, most commonly doesn't. The kids would be itchy, uncomfortable. And oftentimes people don't come in to see me for lice. I kind of randomly note it, and then I treat it, but surprisingly, they're not complaining about it, which is, of concern. So if you do have a situation where there's a kiddo with lice in a classroom, it's unlikely that they spread it to other classmates, except if they were sharing hats or combs, or sleeping on similar bedding, or resting or napping on similar bedding. It's a good idea to kind of inform the other families, but the likelihood that they spread it is not so high for lice. So other family members, close contacts, they should be examined. Play areas and furniture can be vacuumed. Headgear should be machine washed. If needed, you can actually just put whatever was used in a bag for 2 weeks, because if the lice doesn't get a meal within 2 weeks, they don't tend to survive. So that's a good thing. But if the cubbies are shared and the hats go in there and the things go in there, it may be worthwhile to disinfect those areas. All right, scabies. Scabies also, unfortunately, very common. Scabies is a mite that actually burrows into the skin. And if I have like family members that are coming to me and they're all itchy, I tend to just treat empirically for lice. I'm sorry, for scabies. And so the scabies mite, sometimes you can just notice it on the hands, you can notice it in the groin and other areas, or you may not even see it at all, okay? But you have to have a high index of suspicion for it because it's pretty miserable. It like keeps the kids up at night. It's super itchy. Even after you treat, you still may be itchy for a good 4 weeks because the mite, when it burrows into the skin, it lays eggs, it poops. And so it takes about 4 weeks for all of that skin to get shed that it's pooped and laid eggs in. And so the treatment for it is actually a topical cream called permethrin, and we do it overnight to every nook and cranny, every member of the household, and then repeat it in a week. And then all the bedding, the towels, the clothing gets washed in hot soapy water. And that should really do the trick. Sometimes if the scabies have been there for a very long time, the skin overlying can get crusted. And so you look at this picture and you're like, well, it doesn't really look any different from so much of the hand rash that I see. And that's true. But if it's something that's chronic and if they're itchy all over, you have to think of scabies. In order for scabies to pass from person to person, they do have to have close contact. So typically with family members, it does get passed, but if the kids aren't really holding hands or whatnot, it's unlikely that it would have spread through a classroom, okay? But it's just something important to keep in mind. Warts, also super common. Warts are kind of tough because the body may not even recognize that they're there. So it's not really actively fighting it off because it lives so high up on the surface of the skin. So we have destructive and topical measures that we use. But again, warts are something so common that it's not something that we keep kids from activities because of warts, but to minimize the spread, it's not a bad idea to keep them covered, especially if like they have them on the feet or they're doing things barefoot. So that's something to keep in mind. So if there's swimming pools and things like that, with practices, obviously using flip-flops and things like that, just to minimize the spread of something so common. Molluscum, I'm sure, molluscum, I always tell parents when they come to see me, it's kind of a childhood rite of passage, okay? Molluscum, they can last a few months to 2 years. We're not going to keep kids from school or activities because of something that eventually will go away, that is a nuisance when it's on this, on the skin just to look at, but otherwise is really self-limiting, okay? So molluscum loves spreading through water, through shared towels. Kids constantly get it. They get it from the swimming pool. They get it from each other. So the main thing is that if they are doing any sort of contact sports, these should be covered. And ideally these would be covered, but again, we're not keeping kids out of anything because of something that's lasting this long. The treatments for it sometimes are like worse than the bumps themselves. So I don't, by no means in my clinic do I force people to have their molluscum treated because the destructive measures can be painful, it can be irritating, and this is a self-limiting process. Like this will all resolve, okay? It's a benign viral process. But again, sometimes they can get inflamed, they can be a little tender. That's actually a sign that the body's finally recognizing them and clearing them. So we call it the beginning of the end sign, but molluscum, again, are super, super common. In kiddos with eczema, sometimes they can get a little bit of roughness around their molluscum, which can make them itchy, so we treat that. There are, things that we can do in the office, but again, by no means do we kind of recommend, if a kiddo is not developmentally there, that it bothers them. Like the preteens, they want every little bump removed. But the kids, they're just kind of like, whatever, it doesn't bother me. And it's true. If it's covered, they're unlikely to spread it. Okay. So if they're sharing the bath water, the bathtub, their towels, they're going to spread it, but otherwise unlikely to spread it to their classmates if it's covered. And these are how they look when they're starting to get inflamed. They're a pox virus. They will all go away. So nothing too much to get worried about with molluscum. All right. So for fun, I'm going to do some cases. Now, I don't know if you guys, if it's okay to unmute to answer. I'll leave it up to you guys with what you want to do with that. If not, if I don't hear any responses, and if you prefer not to, then I'll just tell you what it is. But this is Molly. She presents with these lesions on her arms and legs, and Molly's not a real person. This is just an example. She only had one spot yesterday, but today she has a few more, and she has been sent to the nurse's office. She says that they are a little itchy. So should we make this fun and interactive, or I should have asked you guys before if it's okay to do this, but
Yeah, you guys can either pop in the chat with your answer or unmute. Either works well.
awesome. Okay. Does anybody want to write what they think this is, or if you want to unmute and tell me? So I'll describe it to you. To me, they look like flaccid bulla. So bulla are blisters, flaccid bulla with like a honey colored crusting. You can tell that they're very superficial. So they're not very tense bulla. And they're just these little subtle erosions. And they're not something that I've already discussed. So they're not eczema, they're not molluscum. There's something that I haven't discussed yet, which will happen in your schools for sure. And it is fairly common, and this does like to spread. Yes, it's impetigo, exactly. So impetigo is caused by staph or strep. It is common, common things being common. Let me see. So these erythematous crusted plaques, erosions, honey-colored crusting, you got it, it's impetigo. It can be bullous or non-bullous, and typically we can treat it with topical antibiotic or with an oral medicine. Sometimes it does clear on its own. These are contagious, okay? However, there's no exclusion from school if treatment has been initiated and as long as the lesions on exposed skin are covered, okay? So that's just something super common. These are more pictures of impetigo just to kind of get that across. These flaccid blisters. So flaccid meaning that they're not very tense, they're very superficial. They kind of, you see the blisters and then they turn quickly into erosions. This is another picture of what impetigo looks like, okay? So very, very common to see this. So what else can look like this? Because this is, you know, you can see herpes looking like this. You can see Coxsackie looking like this. You can see allergic contact dermatitis looking like this. So if kids are allergic to eating mango off the rind, it can look like this. Picking disorders can look like this, okay? So it's not that this is only impetigo, this is impetigo, but there's other things that can be easily confused for it. So herpes can look like this. So cold sores is herpes. Herpes is HSV. It can be HSV1 or HSV2. Herpes is contagious. Typically, the first bout of herpes can be pretty gnarly, can be pretty bad, where it can affect the whole oral mucosa. It may affect like the kid's eating because it can be really painful. When a kid has a cold sore outbreak, they can pass it along to others. So they shouldn't be sharing drinks. They shouldn't be giving each other kisses on the cheeks or smooching because they're going to spread it, okay? But any cold sore, that's herpes, okay? So that's, it can be dangerous if it's around the eye, but these are super common. Sometimes when kids come down with other illnesses or even with like lots of UV sun exposure, they may flare, okay? So this is herpes. It's common. More herpes, again, so they look like these little vesicles. If a child has active herpes, they should not be doing like any contact sports like wrestling, okay? Because they're going to spread it really easily, okay? But otherwise, it's not a reason to keep anybody out of school. This is kind of what herpes looks like on the skin. Wrestlers will get everything. They will get impetigo from each other. They will get fungal infections from each other. Molluscum, herpes, they will get everything, okay? So the wrestling group, because they're kind of grappling and they're kind of skin to skin, they will literally get everything imaginable, okay? So I'll harp more on that point in a little bit. If a child has underlying eczema, their herpes can kind of spread everywhere, and this can be really miserable for them. And so with the younger kiddos, it may actually affect their feeding. They may have to be admitted to the hospital. But a kid with like baseline eczema, if they do get a herpes outbreak, it can be pretty uncomfortable for them. And so they do need to seek prompt medical attention. This is more eczema herpeticum, where basically the herpes kind of infected where their eczema is. By the way, Coxsackie can also look like this. So there's atypical forms of Coxsackie, and there have been quite a bit of Coxsackie flares. So a few weeks ago, there was like a huge wave of Coxsackie. I'm seeing a bit more coming through now too. So there may be a second wave coming through. So this is case 2. Charlie is back at school after being out the last few days with a sore throat. He had no fever, COVID was negative, and his little sister is in preschool. So what do you think this is? Let me open up the chat so I can see, or if you just want to chime in, what do you think this is? Yes, this is Coxsackie, exactly. So, you know, everything's on a spectrum. Not every kid will present the same way. All three of my kids had Coxsackie 6 weeks ago, and they all presented in different ways, and they got it from each other, okay? So some kids will have a fever, some kids will have many lesions, some kids you can barely feel it on them. Basically, the guidance is that they can return to school 24 hours after a fever, but if they have open weeping lesions, then they're contagious. If they have oral lesions and they're shedding it, then they're contagious. So typically it would be prudent to keep them out for a few days, but the really rule of thumb is really if they're not febrile for over 24 hours, their likelihood of spreading it is less. Now, you know, if you are in a location where you have diapered children, it is shed in the poop for weeks. So there's stringent hand washing anyway, but it's just something to keep in mind. Oftentimes you do have, you know, like your patient zero is somebody who has like a sibling in preschool because it spreads like wildfire there. But Coxsackie is very, very common. And in your older kids, it can look like this, just these kind of like little under the skin, they almost look like blisters, these little vesicles. And so there have been atypical forms of Coxsackie that have been a little bit more gnarly looking, where it's just kind of all over. And typically Coxsackie will last for about a week or two. In kiddos that are, you know, get it a little bit more uncomfortably, they are febrile when they first get it. And so they have fevers, they can have chills, and then typically that subsides, and that's when you start noticing the skin lesions, okay? But if they have open sores, they really shouldn't be in school, but this can take about a whole week to fully resolve. But again, if the lesions are pretty much crusted over, if they're just in the healing phase, they're really unlikely to spread it, and they're otherwise feeling fine. Adults can get it too. I only have had Coxsackie 3 times as an adult. So it can happen, and there are different strains of it. Some strains are a little bit gnarlier than others and can have other systemic effects, but the ones that we've seen circulating, especially from the cutaneous side of things, tend to have been self-limited. There are other strains that can also cause some kind of more serious respiratory concerns, but typically their cutaneous findings are minimal. All right, case 3, Selena came to school with no issues in the morning and came in from recess feeling itchy. She's breathing fine. She has no perioral swelling or tingly throat. So what do you think is going on with Selena? So of note, she didn't have it in the morning, but she came in from recess back with it, okay? So this is how hives would look. So hives, urticaria, basically are these wheels, right? So they're these like edematous looking wheels for some reason. Oh, there we go. Edematous looking wheels that really can pop up out of nowhere. And sometimes you're looking at a kid and you're like, they must be itchy, but they're not complaining of it, but you see this migrating rash. So one spot of urticaria will tend to shift within 24 hours to another spot. So in kids, the majority of the time, urticaria tends to be like a post-viral or post-infectious phenomena. Sometimes it could be secondary to a food or other contact. Most of the time, we don't find out why. Now, listen, if you have a kiddo with a known history of severe food allergies and they're coming in like this into the nurse's office and they're complaining that they have a tickle in their throat, like use the EpiPen, right? Like that's a kiddo that you're worried about, like, oh my God, what if they came in contact with something and then they're having like a, God forbid, an anaphylactic reaction. But for the majority of kids, if you're not seeing like active swelling of their mouth, or if they're not complaining about their breathing, or they're not talking funny, or they're not saying that they're tingling, but they're just a little rashy and they're otherwise comfortable, this is probably just urticaria. And in the majority of kids, it tends to be post-viral. Again, different from your patient population where you're like, oh my goodness, are they having an anaphylactic reaction, right? So this is typically treated with oral antihistamines, not topical, but oral antihistamines. And typically the doses that are needed to control hives tend to be double, the quadruple, what the dose says for your Benadryl or your Zyrtec or things like that. But this is what urticaria looks like. This is what hives look like. Again, to differentiate from like the kiddo that has hives and facial swelling and a tickly throat and are concerned about a potential like serious allergen exposure, okay? So case 4, Robbie is so excited for his wrestling match later this afternoon, but his coach notes this on his scalp. Can Robbie participate? So what do you think? Right, Robbie cannot participate because Robbie has tinea capitis, right? So tinea capitis, so ringworm is just another name for fungus, right? There's nothing worm about it. So tinea, aka ringworm, these are fungal infections. When it's involving the scalp, Robbie cannot participate until he's been on treatment for 2 weeks if it's a hair-bearing area. Okay, so he needs to be on oral treatment for 2 weeks, okay? If it's on the skin, then typically topicals will suffice, but if it's on a hair-bearing area, they actually need oral treatment, okay? And so you may look at the picture on the left with the facial lesions, and you'll be like, wait a minute, this just looks like the kid with the hives. But these are not moving around day to day. These are actually there, they're scaly, they've been there, okay? And if a kid comes in this severe to me, I'm actually gonna treat him with oral anyway, because it may be a bit of a challenge to clear this all with topicals. But again, if there's a hair-bearing area that's involved, and if they're doing a contact sport, then they really need to be on treatment for 2 weeks. Now, can the kid be in school? Totally, he can totally be in school. So it's just he can't wrestle other kids. So once treatment has begun, child may return to school, but should not share combs, brushes, helmets, or other items that come in contact with the scalp, or play contact sports for 14 days to avoid transmission. All right, so care of the young athlete. So this is a great resource that's from, it's made by the American Academy of Pediatrics. So it just goes over when you are or are not allowed to participate. So if there's minor cuts or scrapes, then those should be covered because you don't want other kids being exposed to potential pathogens through the blood. So you want to make sure that any sort of open wounds are covered. Friction blisters, if they're new, you leave them intact. If they're open, they're covered with a bandage. So for like nipple dermatitis, those would be covered and treated. Poison ivy, poison oak, you would cover them. Psoriasis, vitiligo. Again, these are not things that anybody's going to pass along to anybody else. These are inflammatory conditions. They're not contagious conditions. So it's actually, you know, preventing the patient, the person who has it from it getting worse. Impetigo or boils, that is contagious. So then they should not be participating. Acne, there's no limitations. Herpes, they should not participate if it's going to be a contact sport. Warts should be covered. Tinea, they should not participate if it's a contact sport and if they're not under appropriate treatment. Sun sensitivity disorders, they should be appropriately protected. Inherited blistering disorders, they should be appropriately protected. Hives can flare. Hives can last weeks, by the way. And other long-term skin problems, no, unless, you know, no reasons to keep them from any activities unless there's some sort of concern there. So this is a great, if you wanted to pull something just to have as a reference in your office, this is a great reference to pull because it does go over the different infectious diseases associated with organized sports and outbreak control. By the way, the lecture goes over common things that you'll see, but it's not necessarily comprehensive to everything that you'll see. So you will see things that are not in this talk, but that are still fairly common that you'll see with kids. So with fungal infections of the scalp, they need 2 weeks of treatment. With fungal infections on the body, they need 72 hours of treatment. And this is for participation in sports. They can return to school once treatment's initiated. So this is mainly for their sports activities. So I want to switch gears because you guys are truly on the front lines, and you, as much as we are mandated reporters. So if we are seeing things that are potentially concerning, we do have to report it, because there is a risk that the child is being potentially abused or neglected, and intervention is necessary. Okay, but it's not necessarily something that you need to have the complete onus to investigate. You do have the onus to be the mandated reporter, and you don't have to necessarily tell the family that you're reporting them, because that may actually be something that may put them in harm. But just as a reminder, we are all mandated reporters if we're seeing signs of abuse. So what are signs of abuse? So bruising in atypical locations. Kids fall, kids play, kids get bruises all the time, but there's certain locations that should give you some pause. So injuries to the eye, or both sides of the head or body, or the ear, or specifically the earlobe, areas that are just like, how did they get that? Like, if there's not a good reason for how they got that, that's something that should give you pause, and it's worthwhile to kind of think about, could this potentially be from abuse? So frequent injuries of any kind, bruises, cuts, burns, bite marks, especially if they can't really tell you how it happened. Distinctive patterns such as grab marks, bite marks, cigarette burns, impressions of things. So I'll show you what that can look like. So this would be pattern trauma from a lighter. So that would be highly suspicious. Healing linear marks, potentially from whipping, that would be of concern. Okay, and this is from an iron. So these pattern marks from an iron. Now, if you have kids and they have their Chromebooks or the laptops, and they have pattern marks from like the heat, that's different. This is like a younger kid on the side, and so that's concerning for like potentially like an exposure to an iron. So I did put the number here for mandated reporting. I do think, you guys probably have all of this information in your offices, but I just, any talk about cutaneous lesions, and especially with you guys seeing the kids, just always keep it in mind as something that's important to note and to appropriately address. All right, so what's not abuse? So mimickers of abuse, but not abuse, is coining. So there are traditional practices that you should keep in mind that are not abuse. So sometimes if kids have, a chest cold or a cough, there is a practice of coining where they actually rub like a warm coin on the back. That's a kind of a therapeutic technique that's more of an Eastern tradition, kind of medical, alternative medicine type of approach. That's not abuse. Same thing with cupping. Cupping is not abuse either. That's almost like creating a little vacuum. Now, I don't comment from the efficacy of this standpoint, but this is not abuse, okay? So these are just traditional practices that are not abuse. So it's important to know what's cultural practice and what potentially is abuse. This is not that. These are mimickers of abuse, but this is not abuse. And then to round out our talk, social media, a huge toll on the, I would say, the mental health of our children, a huge toll on this is potentially an addiction, right? So, but there's also things that the kids have been doing to their skin because of social media phenomena and challenges, okay? And there's constantly new things that are coming up, but it is important to recognize because it almost will spread just as much as an infection through the school, this sort of like social media challenge where the kids can constantly, challenge their friends, and then it becomes almost like a little pandemic in your school of this. So it's important to recognize it, to address it, to really take this from a preventative approach, because these things are dangerous. And so some of them more dangerous than others, but unfortunately, the judgment here is lacking. They just do it because they either saw it on social media or their friends did it, and they can really hurt themselves. So the friction burn from eraser challenge, literally they're rubbing their skin with their eraser and forming a wound there. So if you're seeing these linear marks, best to address it, best to put the kibosh in it, and best to really educate them. Like, don't do it just because your friends are doing it or because you saw it on social media. It's just not a good choice. The salt ice challenge, basically they're using ice and salt together to actually lower the temperature of it, and that is causing like burn marks on their skin. So these are multiple geometric thermal injuries caused by the salt ice challenge. Seeing like, well, how long can they keep it on there? How tough are they? And it's as adults, we're like, this is such lunacy. But for kids, they're like, haha, I'm doing this challenge. I've seen it on my social media threads. Let me try this. But these are problematic. Also, sprayed aerosol deodorant, also that can cause some thermal injuries where it can get really cold. And these can leave lasting marks on the kids, okay? So, this is not the worst thing that they could be doing, but by no means is it something that, we want them to be doing, right? So these are not appropriate activities for kids to be doing, but unfortunately they're doing it because they saw it on social media. They may also try to tattoo themselves, not realizing that these are permanent. So sticking and poking like the pen into their skin, creating permanent tattoos. They may actually do a fire challenge where they try to set their skin on fire. Again, not smart ideas, but things that we have seen. And then slime. Unfortunately, slime dermatitis, it's not like kids love making slime. There's activities in schools to create slime. These are not products that were intended for us to immerse our hands in. And so it can cause a fair amount of irritation, a fair amount of rash. I actually had a parent tell me that their kid could not stop making slime or doing slime because they had an Instagram feed and they had sponsors. And so they were coming to me for the slime dermatitis, but they were not willing to stop sliming. So unfortunately, things like this happen, but not something that we want to encourage. Viral exanthems are very common. Most resolve without issue. Some can last weeks, ranging from like 6 to 12 weeks, sometimes shorter, sometimes longer. But again, it may or may not be seen before them being having any sort of other symptoms. Measles, the majority of the children in your schools will be immunized, but if you have a child coming in with a morbilliform, which basically means measles-like rash with cough, runny nose, and conjunctivitis, and they're not immunized, that may be measles, okay? And so that is something that is reportable. That is something that is super contagious, it's aerosolized. So hopefully we don't see it, but I bring it up because there may be kids that have medical exemptions and things like that. But in New York State, the majority of your kids will be immunized. Parvovirus, again, a frequent common viral infection. This is parvovirus B19. I show this little graph here because typically when they're febrile, they don't yet have the rash. And when they're viremic, meaning that they're peaking and they're shedding the virus, it's typically before their rash comes. So by the time the rash comes, they're not contagious anymore. I don't have in this PowerPoint, I didn't put in pictures of things like pityriasis rosea, which is a super common rash, and other things, but viral processes are so common. Chickenpox, the majority of your kids will have already had immunizations to chickenpox. Your kids can actually develop zoster, just like as adults we can develop zoster, but these chickenpox tends to be dewdrop on a rose petal. So you see these like subtle little vesicles with the surrounding erythema and different stages of crusting over, okay? So this is chickenpox. Again, not something that we're commonly seeing because most are immunized. And so I want to thank you guys. You are the true heroes on the front lines. If there's any questions, I can answer them.
Thank you so much, Dr. Fennell. That was so comprehensive, and we thank you for all this information. There looks like there was some questions. One was regarding behavioral changes. When you were speaking about behavioral changes, what are the behavioral changes we should look for that you mentioned earlier?
Sure. So if they're tired, if they have a fever, if they're really uncomfortable, okay. So like basically, lethargy, tired, if they're saying their belly hurt, anything else that's off.
And then someone asked if you could share the sports related restriction handout, that one pager with the restriction.
Yeah. So let me go back if you just want to screenshot it. This one?
Yes, that was the one, I believe. Yes, thank you for that. Okay, any other questions we have before we end? We want to thank Dr. Fennell for this amazing, very comprehensive. I know I learned a lot. I appreciate you adding the social media component as a parent of teenagers. So I definitely want to thank you for that. If there's any other questions, we can end. Michelle, do we have anything we want to let our participants know for our survey or post-survey?
Yes, so just a reminder to everyone that we will be sharing out information next week, including the recording for this, and you will be getting a link directly to fill out the evaluation for your continuing education credits. We also will, as always, include the link to register if you have not already for our January program. That will be Thursday, January 20th, same time, 4:30 p.m., and that will be on bleeding disorders. But of course, most importantly, everyone enjoy a wonderful, happy holiday season. You all deserve it very much. Enjoy that very, very important break from school with your family.
All right, thank you
so much. Good night,
Thank
everybody.
you.